Hello, I'm Dr. Lauren Schumacher, one of the child and adolescent psychiatrists for the CalMath portal. Welcome to our webinar today on understanding gender dysphoria in youth.
Want me to forward it?
Yes. We have a couple announcements before we get started. You may have heard we have a new name for our service. CAP is now CalMath, the California Child and Adolescent Mental Health Access Portal. And as reminders for more personalized guidance on how to apply today's teachings and other webinars to your own patient's care, please call us. You can call us at 800-253-2103 or request a consult online at calmath.org. We also now have our monthly webinar series recordings available online on demand. You can view the webinar recordings on your own time and answer questions afterwards. If you get a passing score, you're eligible for CME credit and Mach 2 part credit for the AAP. And to sign up, you can go to the link below. You can also access them through our website. And no one involved in the planning or presentation of this activity has any relevant financial relationships with commercial interest to disclose. UCSF now CalMath is supported by federal and state grant funding, including HRSA funding. It's also sponsored by the California Department of Healthcare Services, Prop 56. And now I'm delighted to introduce Dr. Shawn Giammattei, PhD, who's a clinical family psychologist in private practice in Northern California and the new Associate Director of Mental Health for the UCSF Benioff Children's Hospital Child and Adolescent Gender Center. He is the founder and CEO of the Gender Health Training Institute, the Trans Family Alliance, and Quest Family Therapy. He specializes in family therapy with couples, families, and individuals across the lifespan with a particular focus on transgender, non-binary, and gender-expansive youth and their families. He is a GEI SOC 8 certified mentor for the World Professional Association for Transgender Health and is on faculty for their Global Education Institute. He is also a trans health researcher, author, international speaker, and professional teaching graduate and teaching postgraduate courses in LGBTQ, psychology, and family systems. He's also an advisory member of Mind the Gap, a group dedicated to gender-affirming care for trans youth and their families. And he is the author of several articles and book chapters on gender, sexuality, and family work. We're so excited to have him here with us today.
Thanks a lot. Yeah, I wear a lot of hats. My work. I also want to note, I don't think I have a slide in this about who I am personally, but we'll see. If I don't, I will let you know a little bit more about that and how I show up in this work as well. I first want to start with situating how I talk about things and what my focus is, and what I hope your focus will be as well, is that I believe we help gender diverse youth and their families survive and thrive, not by focusing on their difficulties, but by recognizing the brilliance, creativity, and resilience inherent in their bonds. And we spent a lot of time, and you're going to hear a bit today about some of the minority stress and the kinds of experiences that people have out there and the influence of gender dysphoria. Oops. But I want to also pay attention to resilience. Resilience is an important factor in all of this. It's actually helps with the overall health and mental health. And there is a lot of resilience in the community and in the families that you'll see. So as we look at all of that, always hold that in mind. By the way, my slide deck is having a mind of its own. So if it goes forward without me, it's part of it. To start with this, I actually want to talk a little bit about the tenets of gender affirmative model, because the gender affirmative model is the model we use in the Child Adolescent Gender Center. It's also a model that gets it's getting a lot of negative press in the media. And a lot of that has to do with misunderstanding of what the model is. So I want you to understand what the tenets of that are and where we come from when we're using a gender affirmative model, so you know what we're talking about. So we believe the foundational concepts behind the model are that gender and sex are not the same thing, that gender identity and gender expression are not the same thing, that gender identity and sexual orientation are different constructs that influence each other, and that we all have both. Also, there is this model of the traditional model around gender. You've heard about the binary gender model. If you haven't, I'll tell you about it now. This is this idea that there's only two sexes. There's male and female, and if you're male, born male, biologically sex is male, then your gender identity is going to be as a man, your gender expression is going to be masculine, and your sexual orientation is going to be towards women. So you're going to like women. If you are assigned female, then your expression is you're going to see yourself as a woman, you're going to express yourself in a feminine way, and you're going to be attracted to men. Anything outside of that is seen as pathology in many sense in the binary model. So even sexual orientation that falls outside of that realm is considered problematic from that standpoint. And what we do know in the human body is that there's more than just two. We have also folks who show up with the intersex experiences. And so they're, so there's more than just that. And I also want to state that although I have male and female on opposite ends here, that they're not polar opposites. They're one point on a sphere, if you think about it more spherically, of this experience or of gender, and particularly around the biological sex. There's all different kinds of ways you can show up. A majority show up as male and female, but there are a lot of folks who don't fall in that camp. And then for those who are whatever your assigned sex or your biological sex is, or your hormones, your genitalia, all that stuff, how you express yourself is also or how you identify yourself is very different. So you may be assigned male at birth and identify as a woman. You may identify as gender expansive or non-binary or something else in that category. So same thing. So that where how you identify really has nothing to do with your biological sex or your assigned sex. We don't like to use biological so much anymore because we're all biological regardless of what our gender is. And then out of that gender identity, how you show up, how you express yourself in the world, how you dress, posture, all your roles, all that stuff, that's even more expansive. So, we see that people can be whatever their assigned sex, they might identify as certain gender, but they might show up presenting it in a whole different way altogether. So I have folks who were assigned female at birth who identify as men, but still dress in ways that looks very feminine or female. And that's an authentic representation of who they are. And then when it comes to sexual orientation, it's pretty much all over the place. Regardless of where you are with your gender and your gender identity and your gender expression, you can be attracted to anybody or nobody. It can fall all over the place in that. So this is more of an updated model of what we actually see. And I'll just say for myself, if I was to put myself in this whole mix, I'm a man, I identify as a man. I was assigned female at birth. And so I would be up there, except for right now, I don't identify with that either because my body, due to the medical treatments that I've had, is more intersex. So I might put myself in an intersex and biological sex. Man is my gender identity. My expression tends to be pretty masculine. On occasion, it's androgynous, depending upon where I'm going. And my sexual orientation, well, it shifted over the course of my transition. And so I was primarily attracted to women. And over time in my transition, I became primarily attracted to men. So you would see I would fall in some very unique places in that. And what I would invite you to do is you can take this, you've got this in the slide deck, figure out where you land and notice where you are when you really start looking at all of these pieces, because this is an experience we all have, regardless of where we started and what our gender expression and identity is and our sexual orientation. So the gender affirmative model also says that gender variations are not disorders and that gender presentations are diverse and varied across culture, requiring cultural sensitivity and humility. So we do know that social presentation, the social expectations, is very culturally specific. So, so understanding how to do that, how to understand what is okay and not okay within a particular culture, how they view various things, it can be very different. But all across the board, we'd see gender variations as just that we have a lot of diversity around gender. We also believe that gender involves an interweaving of biology, development and socialization, culture and context, and it develops over time. So again, it's nature and nurture, nature, biology, and development. And then nurture is partially development and socialization, culture and context. And then this idea that it develops over time is really important. There was this notion that you had to know who you were at 6. By 6, everybody, we all had to know. We'd discover our identity, we'd figure it out, and we'd solidify by the age of 6. That's not actually how things are rolling out these days. And what we're noting is that a lot of people may know their identity as 6, including a lot of transgender people. But for a lot of folks also, it evolves over time. And then I also find that the expression of gender and how we present ourselves absolutely develops over time for all of us. There are times when we're super gendered, and there are other times where we're really fluid and more expansive. And I see as we age, we tend to get less aligned with some of that stuff. If any of you've noticed, I noticed that sometimes older heterosexual couples start to look like each other later in life. They just kind of, there's not as much of that distinction as there was when everybody was younger. So this happens for everybody when it comes to that. We also believe that a person is the expert on their gender, regardless of their age, that gender may be fluid and is not binary. We also don't inadvertently blame clients for the impact of discrimination and internalized transphobia. We believe that pathology, when it's present, is often related to interpersonal and cultural reactions to a person, and therefore pathology more likely lies in the culture rather than the person. So this is this idea that, really, I would say that if you're out there in the world experiencing the world with the level of minority stress that transgender people are experiencing, you'd probably show up with some psychological difficulties as well, a lot of anxiety and depression and that kind of stuff. So the ways that people are showing up has more to do with that. And we believe that expressing one's authentic gender may actually be the cure rather than the disease. We also have a definition of gender health, which is the opportunity to live in the gender that feels most real and or comfortable, and the ability to express that gender with freedom from restriction, aspersion, or rejection. So when working with gender diverse youth, there's a couple of things that you need to know and think about when you're doing that. Recognize and respect gender diversity and the unique gender journeys that people have. So acknowledging that there's all these ways that people can show up, and there are unique ways that they navigate their developmental process around it. Recognize the potential impact of mental health and well-being. So how this all can impact, including the minority stress. Show compassion for the experience of parents while not ignoring the child, which sometimes can be difficult when you've got a parent who's in a very different position than their kid is. So being able to really acknowledge and mirror the child while at the same time not alienating the parents if they're not on board, which many aren't when they first come to primary care, which you can often be the first person that they see that they come in to talk about this stuff, and they may not be aligned with their kid. Recognizing your role in creating inclusive environments. And this is really important. You have a powerful impact in how you show up with your patients. So one of the key pieces of understanding what to do is to know the terminology. Now, I go through a whole laundry list of the gender affirmative areas of focus that providers need to have. I'm not going to go through all those today, but what I want you to know is know the terminology. And that's the place where you want to start. If you don't know the words and the language of the community or that the kids are using, then when they use language and you don't get it, they'll go, "Oh, I know you're not affirming, or you don't get it," and they will possibly shut down. So I actually created a glossary. It's 46 pages long. It's got a lot of words in it, and I will tell you it's not exhaustive. And at the date I put it out, it was outdated because the language is constantly changing. But it'll give you a basic overview of what the language is and what's okay and what's not okay, because certain language falls out of favor. I'll give you an example. We used to use gender variance to describe kids, and then that was not okay. In fact, I was working on a book chapter in the gender affirmative model book, and we had to change it, I think, 5 times the language we were using, because over the 2 years that we were developing that book, the language changed. But we started with gender variant, then it was gender nonconforming, and then that wasn't okay. And then we were gender creative, and then that wasn't okay. And so then we moved to gender expansive. Now we've moved beyond that. And I use it interchangeably with gender diverse. So that's just one area of language where things are always evolving. So knowing the language and knowing what kids are using when they're talking about their sexuality, when they're talking about different gender identities, it's great to know, sort of have a background in that stuff. So this is freely available to anybody who wants it. Understanding puberty. So puberty is really important in all of this. And I wanted to highlight this a little bit because most youth present for treatment at this time. The kids that come in younger, it's because their parents are worried they saw something going on and they're trying to get access to somebody who can tell them what to do with this. But for a lot of kids, they show up in puberty. And we also find that for young gender diverse kids, gender is not the central identity for them when they're young. They may be doing fine. Nobody's bothering them about what they need to be doing. They're being allowed to sort of be who they are. Oops, sorry. Some youth report not thinking about gender much until adolescence, so they just don't think about it. They're having a good time. Their bodies are pretty agendered, or they're just sort of moderate. As long as they're not boxed into something that doesn't fit them when they're younger, they tend to do pretty fine until their body starts to change. And some gender diverse kids also imagine that they're going to become the gender that they identify with when they grow up, rather than their current birth assigned sex. So some have some magical thinking that they believe, or maybe they think God will come down and make this okay. It's all going to turn out the way it's supposed to because I know who I am. Especially if they're affirmed by their family, there may be this sense that some things are just going to go along and they're always going to be who they are, and not really having a good sense of the embodiment part of that, how that might show up. That can be one. I have one young person I worked with who is also, I would say, is on the autistic spectrum, who really believed that he was going to just get taller. He knew about puberty. He wasn't worried about it. He thought it meant you got taller, but his body would stay the same. So when he started developing breast and menstruating, that was completely freaked him out. So there's lots of ways that kids can show up, but this is the time that majority, even though there are some folks who say that this is late, it's actually not. It's when most kids show up, at least in my practice. It's also important to understand that puberty for transgender, gender expansive youth can be excruciating. And for some, it's the body changes are experienced as a betrayal. If they expected their body to go another direction and now it goes this direction, that can be very upsetting, especially for those kids who are having some of that magical thinking, or who just believe something else happened in puberty, right? For others, it's a catalyst for change. They realize this thing is happening. They're like, oh no, this cannot happen. I need help to stop this. The changes also that are occurring in their bodies are completely out of their control. So, your body is just doing what it's doing. So it's a little bit scary to not have control over something and it's going the wrong way. This creates a sense of overwhelming anxiety and panic, which is the dysphoria that we talk a lot about. So emotional and or behavioral difficulties can come out of this: self-harm, eating disorders, suicidality, drug and alcohol use. So these might be some things that if you're noticing some of this stuff coming up there, and there's some issues or some things that are giving you little red flags around gender, that this could be part of what's going on with that. And those are just, I would say, survival tactics to get through what's happening to your body, especially if you don't feel like you have any control over it. So let's talk about this idea of gender dysphoria and gender incongruence. You've maybe heard of some of this. So gender incongruence is different from gender dysphoria. It's actually what's in the ICD-11 as the medical treatment that needs to be happening, or how to deal with that. And what that is that discrepancy between one's gender identity and their sex assigned at birth, and the associated gender role and or primary, secondary sex characteristics. So it's that discrepancy that is the gender incongruence. The discomfort or distress is gender dysphoria. So, not everybody has gender dysphoria. Some people do. Those people who do have gender dysphoria, it can be very extreme, but it comes in all different waves and levels of that. What I want to explain to you is what I think. This is my take, my theory on what gender dysphoria is, what the experience of it is. And I've talked to a lot of gender diverse people who have totally agreed with this. Now, this is not data driven at all. This is my experience clinically and personally. I believe we all have a mental map in our brain of what we're supposed to see in the mirror as a gendered being when we look in the mirror. And this is true for all of us. I think of it kind of like a homunculus, only it's for gender. We're wired in some way to have this image of what, I close my eyes, I know what I'm supposed to see when I look in the mirror. When we're little kids, our mirror is social. So that involves other people seeing us, our parents, our peers, anybody around us. And it involves our pronouns, our name, expectations around toys, the line that you're told to get into, in school, like all those kinds of things are the social mirror. And and part of what you're looking for is to be seen in your mirror. Well, when you become an adolescent, that mirror becomes physical. So now I'm looking in the mirror and I don't see myself. When I'm a little kid, I'm telling people who I am, and they're telling me I'm not. They're mirroring back that I'm not accurate about this. And what that creates is an existential panic. So it really is this experience of I'm looking, I'm trying to see myself. I'm telling you who I am, and nobody sees me. I don't see me. Oops. This is irritating. So it is this existential panic, and it's this idea, and it's not mild for a lot of people. It is really a panic experience of that I don't exist. I can't even see me. And it's really excruciating when somebody's experiencing that kind of dysphoria. There's also another part to it that we call gender noise. Some people have called it gender dysphoria noise, but I find that it goes far beyond the body dysphoria. It goes into other aspects of your experience. And what gender noise is like a nonstop narration. It goes beyond body dysphoria. It's cacophonous, it's intrusive. The volume changed based on context, and it actually never fully goes away. So this idea that you can do all this stuff and make everything go away is not really true. It gets very quiet. Like I can tell you most of the time, I don't experience any of it anymore, but every now and then something can come up and I'll get kind of triggered by something. And it goes away very quickly. For some people, one kid I worked with described it like nonstop screaming, that was what it was like in her head. It involves fears about safety, how others see you or will react to you, how you sound, how you walk, talk, gesture, making sense of microaggressions, those little small things that people do that you don't quite know whether they're problematic or not, but you're constantly trying to monitor and figure out what's going on with that. It also involves, it's a cacophony of negative thoughts, voices, and overwhelming processes that involve all of these things. It makes it hard to think. Jeez. Let's try this again. Yeah, makes it hard to think or focus. It increases isolation. It increases rage and oppositional behavior. It increases anxiety and depression, and it increases suicidality, as well as maladaptive coping. It creates those kinds of those processes. So understanding that when you look at these sort of symptoms that are coming up, if you start noticing some of these symptoms, this may be a symptom that somebody's experiencing this level of stuff. So I see things like ADHD, high social anxiety, a lot of other stuff like that, depression and suicidality, and then kids engaging in things like eating disorders or substance abuse or risky behavior. All those kinds of things become factors. They're solutions to the problem of this experience. And so those are some of the things to watch out for if you see some of these things going on. And I often ask people, it feels like there's like voices in your head, like there's, like 4 to 10 voices yelling at you all the time, and they're not saying anything nice. And it can be very excruciating when it comes to that. There's also this experience of joy. And I don't want to make it all sound negative, because there are these moments where somebody sees you or you see yourself, and it creates this just really beautiful feeling of sometimes euphoria. We stopped using euphoria because it was a little bit too big. Gender joy, moments of joy. Some people just say gender happiness. There are these moments of happiness where things just line up and you feel really good about yourself from a gendered perspective. I imagine, I think about this idea of somebody like a little kid, trans boy, walking into a hardware store, say with his parent, and the guy comes from around the corner and leans down and says, "Hey, young man," to this kid, and the kid just beams. He's like, "Oh my God, this guy sees me." It doesn't just a random stranger, and you see me, and it feels so good to be seen. And it's that mirroring that is so important there. That's why we spend a lot of time with parents, teaching them to really just mirror and listen to their kid and follow them. This is a quote by Milton Diamond: "Nature loves variety. Oops, unfortunately, society hates it," which is sadly the case and what we're seeing a lot of out there right now, which leads to a lot of the minority stress we experience. So some of the stressors surrounding gender diverse kids is discrimination, stereotypes, prejudice, misgendering, lots of misgendering, misnaming, dead naming is what we call it. Losing social status or not having any, not being even included in things. Stereotypes of being predators and mentally ill and all this other kind of stuff that follows you. A lot of violence. When we look at the class climate surveys from GLSEN, the Gay, Lesbian, Straight Education Network, that kids are experiencing mental, emotional, verbal violence, sexual violence, and physical violence in schools. And some of that is happening at the hands of administrators and teachers. So that, and many of the kids don't feel like even if they report bullying or violence, that it's going to be addressed in the schools that they're in. So there's a lot of distress going on around that stuff. A big one for everybody in the trans community is the fear of rejection, either actually being rejected or the anticipation of rejection. There's even been articles written about this experience around the anticipation of rejection. One of the reasons why a lot of kids don't come out to their parents early on is the fear that they're going to be rejected. And the last people they want to lose is their parents and their parents' love. So there can be this distress around that. And there's a lot of lack of social support for kids. What we've learned from the class climate surveys is that kids are experiencing pervasive mistreatment. And even in California, it's not pretty in the schools. It's better here than it is in some other states, but definitely they're still experiencing a high level of mistreatment. They're experiencing pervasive violence, and this is from students, teachers, and staff. They're experiencing discriminatory policies around what bathrooms they can use, whether they can play on sports teams, whether they can change in a locker room. And then there are other things that within schools, you know, there are some schools who are trying to make it okay to out kids. They'll do things around what clothing you can wear and how you can wear it and various things like that. So those things are happening even throughout California. School avoidance is huge. This is one of those things when you're experiencing the place where you spend the most time as this violent or this unsafe or just stressful, kids start avoiding school. So if you're seeing something around school avoidance and there's any question around some of the gender stuff, there might be some of this stuff going on. It's good to check on. So the minority stress cycle was developed around sexual minorities. It was showing that there was a difference in how sexual minorities experienced stress, minority stress, as opposed to those with different ethnic backgrounds and racial backgrounds. But it is this experience of, because you're a part of this group, that you're stigmatized by society, you're frowned upon, stereotyped, misgendered, discriminated against, erased, experience verbal and physical violence, isolation, segregation, lack of resources, which results in this minority stress. And that experience is felt as anxiety, depression, PTSD, fear, paranoia, hopelessness, mistrust, lack of self-acceptance, guilt, and internalized transphobia. And I do want to say, when it comes to internalized transphobia, there is no way for any of us to grow up in the society as it is right now for us to not internalize the negative messaging out there. And we start protecting everybody from us because we see ourselves as these monsters or these terrible people. And kids do this a lot to protect their family, to try and figure out how to do that. And if you want to think about this as how things like this can show up, is there's a statement, some of you may have heard it, this idea that you don't tell your grandmother, it'll kill her. Has anybody ever heard that about something? Well, imagine it being your identity and you know this is who you are and you realize that who you are could kill somebody you love. That's a piece of minority stress that we carry, and it has a profound impact on how we show up in the world. And it's something that plays a big role in this. So some of the ways that we deal with that sometimes isn't the best. We pick maladaptive coping mechanisms. We abuse substances. We engage in dangerous or risky behavior. We can victimize others and also be perpetrated upon as well. We may be aggressive, isolating, get involved in disordered eating, and become suicidal. Parents may actually address this level. By the way, parents are experiencing minority stress as well around this, and they may address it with rejecting behaviors. And most rejecting behaviors by parents who absolutely love their kids are not meant to harm their kids. They're actually in the hopes of helping their kids. They're sort of misdirected love is where I would put it, because they want what's best for their kids. But actually, it's one of the biggest impacts, negative impacts on mental health for gender diverse kiddos. We know that 41% of trans people attempt suicide by the age 30. That's not just suicidal ideation. Suicidal ideation is up in the 90+%, but 41% actually attempt in their lifetime, actually under the age of 30. So that's a huge number, much larger than the general population. So understanding what these impacts are is understanding what the societal and cultural impacts are. So understand the bans on medical care also, even though they're not happening here in the state of California, although they keep proposing laws to try and do it. They haven't made it onto any of our ballots yet. Hopefully they won't. But if you look across the country, this is what you see for youth right now. We have 15 states in the District of Columbia that have shield laws that protect providers and people accessing care from being prosecuted for doing so. We have in that dark orangish brown, we have all the states that have banned gender affirming care across the country for transgender youth, including surgical and medical care. There's 23 of those states right now. So almost half of our country has banned care for kids. And on top of that, 5 of those states have made it a felony crime to provide gender affirming care to these kids. So you also have Arizona that's a little confused. They have banned surgical care as well as and created a shield law. But what I want you to notice there is that even though this isn't happening in California, people are aware of what's happening. So even if the kids aren't, the parents are aware of this kind of stuff happening, and they sometimes don't know how to make sense out of what's happening. But this creates a level of minority stress that is huge for the whole community. Any kid who starts learning about this or starts realizing I can't apply to college in half of the country because it's not safe for me to go there. And I will tell you that Florida in and of itself, when we bring in all the adult care stuff, actually right now has a warning that we're told as trans people not to go there. It's a do not travel state because it's so dangerous there and they have such prohibitive policies there across the board. So that's sort of the state of what we're living in right now, just here in the US. And it's not that much better, you know, as we start running around the world with things that are happening. That creates more minority stress. Also, you might have heard of, rapid onset. You have rapid onset gender dysphoria. I want to address this very quickly. It's not a diagnosis. It doesn't actually exist. It was a thing was coined by a conservative researcher who did research that, in my opinion, definitely my opinion, felt like very undergraduate research. They did a survey of conservative parents through conservative listservs of parents who already didn't believe that trans was a thing or that their kid was trans, and asked them that with their experience, and these parents experienced their kids as coming out of nowhere, that they didn't know their kid was gender diverse, and they absolutely didn't see it coming, and they thought that there was something else going on. And they got into this idea that it was contagion and that kids were trying to be like their peers and all this kind of stuff. In fact, I was on a panel early this morning for healthcare provider or health insurance, and that was one of the questions they asked. Well, how about peer influence on all of this stuff? And so that is out there, is this notion. Well, what you need to know is no children were ever studied in any of this. They have no proof that this is actually an experience kids have. What they have is proof that parents have this experience. So when you hear about rapid onset, it's a parental experience, a conservative parental experience. The other question that comes up a lot is, what if they regret? Can young people really understand what they're doing? Who should be making these decisions? What's the data say? So I'll tell you that what we know is young kids can make decisions between the age of 11 and 13. They understand the process of medical decision making. We've got data on that for general medical stuff, but also for gender affirming care, that the latest is 13 and a half that we see. And those are usually those who are assigned male at birth. So those assigned female at birth are able to understand it even younger. So if you were to use the same criteria we use for adults, for consent, they would be able to give consent, although legally they can't, so they give assent. But who should be making these decisions? It should be the medical provider. It should be, if there's a mental health provider involved, it should be the kid and the family. Those are the people together as a team who should be figuring out what's the best path forward for this kiddo. As a medical provider, you're part of that team. And so figuring out what is the best path forward for the kiddo in front of you is really important. So, and when it comes to regret, I want to talk a little bit about the data. This is data on surgical care. But if you'll notice the red parts in there, that's gender affirming surgical care. The rest of those are other cosmetic surgeries and plastic surgery. And this is level of regret. So we know the data across the country for surgical patients across all surgeries is 14%. That's what people tend to regret. We know that, let me see, 40 to 50% regret getting married, and about 13% of people regret having children. Right. So we also know that 13% of men express regret. Let's see if this is gonna, I don't know why it does that. 13% of men express regret with treatment decisions for prostate cancer. Right. What we know about the regret rates for gender surgery, gender affirmation surgery, is that in the latest study from OHSU, that 0.3% of people who requested a reversal of surgery or transitioned back to their sex assigned at birth over a 6-year period. That's pretty darn low. When we look at the longitudinal data from Amsterdam, the 2018 study, it was less than 1% regret rate for surgery. So, and this is consistent when we look across all of the data, that it's like the biggest I've seen is 3. Part of it has to do with how they're identifying regret and what that means. Some people don't regret at all, but maybe they regret a surgical intervention, but they don't regret transitioning. It's very rare, actually, that somebody regrets transitioning. And if somebody did, I'd want to make sure they were getting the exact same kind of care that anybody else who's on a gender journey, who's experiencing incongruence, would get. The impact of family can't be understated in this. So risk factors for youth increase exponentially when families are not accepting. And each move away from rejecting their child towards tolerance improves a child's well-being, health, and educational success. And I know you're probably not, I mean, you were going to intersect with families, but families are the #1 factor in their kids' overall well-being. So if parents aren't on board, it's really important to help them get the resources to do so, because that's probably one of the best factors in your kids' overall health. This is some of the data that came out of a study in Toronto of the differences of support for trans youth. And the blue is parents who are supportive, the yellow is parents who are not supportive. I think those last 3 say a lot, that, you know, people were not facing housing issues, like they weren't ending up homeless as kids if their parents were supportive. 55% were having housing problems because their parents were not supportive. 23% suffered depression when they had supportive parents, 75% when they didn't. And attempted suicide is a big one, 4% for those with supportive parents, 57% for those without. So they're an important factor. And then if you look at well-being, it's much higher for kids in supportive families than it is for those who are not, you know, when it comes to self-esteem and all that stuff. We know that youth who grow up in highly rejecting families consistently experience lower self-esteem, increased mental health problems such as anxiety, depression, suicidality, and self-harm, were more isolated, felt more hopeless about their lives, and were more likely to drop out of school. Also, it's important to note that there's a lot of data on the lack of family support. A lot of families are not, you know, their kids are not feeling good about being in their families. They're not feeling supportive. They're feeling mocked. But one of the worst data that I saw here is that 97% of all gender expansive youth are having trouble sleeping at night. So another thing, focusing on their sleep and how are they doing around that stuff. It's a big factor. Transgender youth of color also may experience multiple facets of stigma and marginalization, and it's exponential. So it's not, you're dealing with multiple minoritized identities, and we know that they experience more violence, harassment, sexual exploitation. They're forced to continually navigate both racism and transphobia. They often experience racism in the LGBT communities, like they're not allowed, they have to pick one over the other, and the same in their ethnic communities, but they're not allowed, you know, they get a lot of transphobia within their ethnic community. So this is a factor. I also want to say that racial minority groups are not more transphobic than white ones. So not to state that, they just are dealing with another level of distress and minority stress as a part of the process. Also understand that the impact of intersectionality, of the intersections of identity on health, that they're huge, that trans people who have these intersection identities have more health inequities across the board. This was, I think, from the Fenway, one of their things that you can collect. Despite the ill health that transgender people experience, they're often still experiencing even more discrimination, harassment, and refusal of care by healthcare providers. Often some of the things that happen in medical settings are discrimination, misgendering, dead naming, discomfort or disgust by the medical provider, roughness, fear, violence, and avoidance, being denied treatment, confusion even with the basic concepts, which is part of why I said the languaging is really important to know. Sometimes being given the wrong diagnosis and treatment. So like I told you, a lot of those symptoms that were there, people get diagnosed with ADHD and all kinds of other stuff, maybe even paranoia, when they're actually really experiencing stuff that would probably make most people paranoid. So there are ways that they can get negative stuff around that. Being patronized, pathologized, humiliating treatment. The trans broken arm syndrome is one that I'll give you an example. I break my arm. I walk into an ER and they look at me and they say, "Oh yeah, broken arm, but you know, that's a transgender broken arm because you're transgender. We don't do transgender treatment here. We don't know how to do that. So you'll have to go somewhere else for your treatment." So that's one way that a trans broken arm can show up. It's somehow the transgender broken arm. The other way is that I show up with a broken arm. They say, "Oh yeah, it's trans broken arm, but we need to look at some of those other factors that could be involved. Like let's take a look at your hormones and maybe we need to look at your genitals so that we can get a better sense of this broken arm." And so there's a way, and you get like you're a bug under a microscope for people out of their curiosity, as opposed to somebody treating you for the issue that you're there for. Those are things that happen. It actually creates a lot of distress around going to medical treatment, and people are already scared enough to go to doctors, but that increases the level, especially as people get older, and they are more aware of these things. We know that mental health disparities, there's several mental health disparities that have been documented in transgender youth. Depression, suicidality, anxiety, decreased self-esteem, post-traumatic stress disorder, eating disorders, OCD, and substance abuse. All of these things, all of those, outside of some of the anxiety and depression that can be related to the body dysphoria, almost all of that is related to the way you're treated in society and the way you're bullied and treated by your families, all that kind of stuff. So that's a lot of the things that we see are reactions to that. OCD, we have some overlap in some other areas, and OCD can show up not as a reaction to, but it does co-occur often, and it can be hard to distinguish sometimes. People get into the body dysmorphia, and is this actually more of that kind of symptomology as opposed to dysphoria? There's also a co-occurring of developmental differences. There's higher rates of autism spectrum neurodivergence in the community of gender diverse, and vice versa. You talk to people who are specialists in ASD, and they'll tell you, "Oh, there's a lot of gender diversity in our cohort of kids that come in." It's good to screen for this. In fact, the Standards of Care version 8 recommends a screening around this, just to see what's there, because it seems to be very prevalent. It can be important to refer for assessment when appropriate, but not always available because it's expensive. But if it feels like there's an issue involved and that kid really needs some extra resources and they could get access to that through assessment, that would be a good time. There's a big overlap with ADHD. Sometimes ADHD is misdiagnosed because of the extreme level of gender dysphoria or gender noise that's going on, that they get confused by this. But there's also a big overlap of the two. Just to note, there is no evidence that autism is a cause of gender diversity whatsoever. They co-occur. We don't know why they co-occur, but they do. Also, symptoms of autism have not been found to increase after the initiation of hormone therapy. I've found that actually hormone therapy needs to be added a little more slowly, so that because especially for somebody who's got sensory issues, they may need to go through that process a little bit more slowly, so that they can get used to the bodily changes. Even though they're right, they can be a little destabilizing if they ramp up too quickly. but it's different for everybody when it comes to that. So here are some of the possible medical interventions that we'll talk about. There are social interventions, medical interventions, and legal interventions. So social, we're talking about name, pronouns, the presentation, how you dress, your mannerisms and roles, what you get to do, various things like that. By the way, this is what, I mean, all people go through various aspects, usually of social transition. Kids, before puberty hits, that's all they got. There are no other medical interventions available. So if you have a young kid coming in, it's really about following them, figuring out where they need to go with some of these things in the safest way possible, and following them around what that is needed for them. Some adolescents, transmasculine adolescents have a tendency to do a social transition before a medical transition, whereas transfeminine tend to, in my practice, tend to want medical interventions before social. Mostly it has to do with how poorly people are treated who are assigned male at birth who do anything feminine. And they really want to feel solid in their identity and being able to see themselves before they want to walk through the world and do the social part of it. And it has a lot to do with the minority stress. I have a feeling if there wasn't that level, they'd be doing the same, going the same direction in that way. Medical treatments involve puberty blockers, hormones, and surgeries. So for kids, we don't see a lot of surgeries, but there are some cases where that can come up. Mostly what you're talking about is puberty blockers and hormones. Puberty blockers are available starting at 10 or stage 2 if somebody's really dysphoric, or we know that they're going to be extremely dysphoric. So they've known who they are since they're 2, and now puberty's coming in, that they're going to be really distressed if they go into the wrong puberty. That puberty blockers are a really good reversible treatment, so that they can, that gives them a few years and an ability to sort of not have their body go the wrong direction and not have to go through a bunch of other stuff like surgeries and things like that to fix all of the things that an endogenous puberty did to you and taking you down the wrong way. Hormones are available. And by the way, there's no age on this. It's developmental stage. It's where somebody is in that. Hormones are available usually in at the time that somebody would normally be going through puberty, which is somewhere around 13 to 16, depending. But again, it's developmentally based on that kid, where they started and where they were going. Some kids who already went through an endogenous puberty are not eligible for puberty blockers. It would send them into sort of a menopausal type state if they were to do those without cross-sex hormones. So we will add gender affirming hormones to the mix for them at that point. And again, that's something that is started very slowly in kids, and it really depends on their development and where they are and what they need and their level of distress. If we have a kid that's chronically suicidal because of all this stuff that's going on, we're going to be in much more of a crisis mode with them and make sure that they get a really harm reduction in here and get the care that they need, maybe quicker than we would do for other folks. We might start on puberty blockers if we can do something like that, just to hold off on things for a while. I'm going to run out of time. I can tell that. Let's see. Hormones are, I said that. Surgeries usually happen more for transmasculine kids who have developed breasts before they ever got into any of this care. So their body they see themselves very masculine, but they're walking around with breasts, and that's really dysphoric. It's not something that they can wait till they're 18 for, because they're already having that experience. And it's like any other boy who ended up with breasts. They're going to be really upset and uncomfortable, and so limiting to their life that they may get surgeries earlier. Sometimes we have young kids, or not young kids, older adolescents who get gender confirmation surgery, genital surgery, shortly, like around 17 and a half, before they go off when they're still at home. It's a good time for them to have it. And those are usually kids who started early, went on blockers, who they were, went on blockers, went on hormones, and now they're ready to launch into their life, but they want to do so with their body complete for them. And not everybody wants surgeries, by the way. So that's just some of the pieces that are possible. Legal are name and gender marker changes, birth certificates and documents that need to change, and records, which includes all our medical records and things like that, and dealing with insurance and various things like that. So some of the things you can do, and I'm going to whip through this pretty quickly, but you've got some of this, is get their name and pronouns right. This is like one of the most important things you can do. Figure out what they are. And don't guess their name or their gender identity, just ask. Some of the ways to do that is just to say who you are. Hey, I'm so-and-so, these are my pronouns, what are yours? You know, what name would you like me to use? Anything like that, and then stick with those. Same goes for the name, obviously, and use their affirmed name and pronoun whenever you're talking about them. Don't use the other names, especially if you have to. There are certain areas where I have to, around a letter or something, I will tell the kid, look, because your name's not changed, you're going to see your old name in there. That's because legally I gotta name you in this, but that's not, you know, it's just one shot there so that the insurance company knows what's going on. Adolescent care involves a multidisciplinary team, includes access to accurate, culturally informed information related to gender and sexual identities, social medical embodiment options, the impact of family support, connection to others with similar experiences through support groups. And support groups are awesome for everybody, adolescents and their family. These are some of the parental concerns around things that they have common concerns around. Parents often have high levels of anxiety, especially after learning about their kid. And since they're so important, we want to make sure they're getting access to help. This is a gender journey map, and I'll throw this one in there for you because this is the journey that the Trans Family Alliance, the parents I work with there, that we found that they went on, which is very similar to what kids are on. And so part of what I want you to notice, that kids, when they come out, are usually in phase 5. When they come out, their parents are like in phase 1 or phase 0. So they're in different developmental trajectories. It's why they show up differently around certain things. It's very rare that it's the opposite around that. But check this out. This is what parents are going through on their process. They often come into me in phase 2 after they realize there's an issue going on, even if they don't believe it, that they're looking for information. And that may be where they show up with you as well, trying to figure out what's going on and what do we do about this. So here's some strategies for kids: providing affirming care, create safe spaces, referrals for gender affirming therapy, referrals for support groups, access to gender affirming resources and social transition stuff. And here's your 6 basic care steps to providing care, which is to understand the range of gender expressions and differences in embodiment goals, the potential impact of gender dysphoria and noise when treating patients, and allow them to access gender affirming resources, recognize distinctions between sex, gender identity, sexual orientation, understand the differences and similarities in healthcare delivery needs, understand access to care is affected by negative experiences with providers and role providers can play in improving quality of life for trans youth, and understand the impact of minority stress on youth and families. I think that is the last of my slides. Yes. So I will stop the share and I will take any questions. I see you've got a few in there. Hey, I'm good. I usually only 3 minutes over is good for me.
Very good. Thank you so much. So yes, we've got some questions in the Q&A. The first one is asking about gender nonconforming kids in the past grew up to be gay. I'm concerned that such kids these days may be medically transitioned and have irrevocable changes made to their bodies before they can understand what those mean. How to be sure we're not promoting the medicalization of gay kids who will later regret those changes to their bodies?
Yeah, this is coming out of the data set that was actually a misrepresentation of what gender is. So you got to remember that a lot of the old studies were based on gender identity disorder, and they pathologized gender expansive behavior that is often found in the queer community. So this notion that kids who are gay are going to become trans is not actually really what happens. So what we have, when we have kids come in and we're following their gender, we're looking at gender and sexuality and where are you going. Nobody wants anybody to go down a transgender path or a medical path in particular if it's not authentic to them. So what we're looking for is authenticity for that individual kid, and it's very individualized. We don't have that sort of experience happening. Is like based on the sissy boy studies and things like that, where they were actually looking at gay kids who were gender nonconforming in that era and who really didn't identify as a different gender than them, than their internal sense of self. They just expressed themselves in more effeminate ways. That's not being pathologized in this arena. We're here with kids who are actually saying, no, this is who I am, or I feel more like this. This is what I'm experiencing, or this is what I want to be. And we're exploring with them to see, is this the right path? So we're not actually, and that's why I say in the gender affirmative model, we're not sending people down a path of medical interventions unless it's absolutely right for them. And they've been on this path for many years. We're not talking about somebody who's just playing with gender. And we have a lot of people who play with gender and they never go down a medical path and they may identify differently. So just understand where that data is coming from. It was a misrepresentation. It wasn't actually looking at trans kids. And when we actually look at trans kids, we've got it much more dialed in today than we did in the past.
Given the gender fluidity, or the fluidity of gender that you described, doesn't it make sense to defer permanent changes to their body until their brains are mature, typically after age 25?
Well, here's a question I would ask for you. So we allow people to get married, to go to war, to drink, all of those things, to plan their whole lives under the age of 25. Now, I would also say that you, as a human being, probably knew your gender somewhere in that range of 2 to 6, like most people. Why is it we allow you to make decisions based on that and not transgender people? So that comes from, I would say, a very cisgendered or cisnormative perspective that somehow a transgender experience is terrible and pathologizing and that we should stop it and not allow people to do it. The truth is, kids know their gender very young. And even if it's evolving, and by the way, for those people who evolve and move through their gender or who possibly go one direction, decide it's wrong, go another, it's less than 1% of the whole transgender population who gets access to care. Actually, it's 0.3 of that 1%, less than 1% of those folks who actually end up going down the wrong path. So I would ask, when it comes to doing no harm, do we deny access to care to 99% of a population who are well served, who say that this is the best thing that has worked for them, that they're living beautiful lives? Do we deny access to them who we know historically have been suicidal, been harmed greatly out there by not having access to care? Do we say that that's better, that we should do that as opposed to that 1% or less than 1%? So it's this thing, do we deny access to care? If 1% of the people die as a result of heart surgery, do we now deny heart surgery to the 99% who are helped by it? And that's some of the question that I would say. You have to follow each kid, right? If you have a kid who isn't sure about where they are and what they need to do, and they're confused about things, they have other things on board that are going on, that may be a kid that needs to wait longer, right? But we can't make a global decision about that for everybody. The one longer-term study.
The one longer-term study done in US published by Chen in 2023 and New England Journal of Medicine showed 2 out of 315 kids died by suicide despite receiving state-of-the-art gender-affirming care in academic centers. So getting gender-affirming care doesn't seem to prevent suicide. This is also what Hilary Cass found in her recent comprehensive report published in the UK. How do you explain these results?
Well, I could spend a couple hours on the Cass review when it comes to that. It's interesting. All of these questions are based on that same model of things. What I'll tell you is that we do have a percentage of kids that do die by suicide because they have levels of depression and other kinds of things, right? And so what I don't know about that, those 2 children out of 315. So here's this 315 are, so what, 313 are served, 2 die by suicide. So if that's the case, what do we, are we going to be more concerned about the 2? And we don't know what the reasons are. We don't know how supportive their family was. We don't know a lot of the data around what was going on with those kids and what happened with them, how bullied they were being, and all this other kind of stuff. Gender affirming care does not solve every issue out there, and it certainly doesn't resolve minority stress. There's a whole lot that goes into that besides that. When it comes to the Cass review, I just want you to understand that the Cass review was done supposedly as an unbiased review. It would be very much like asking a white person to do a review of a treatment for Black people and refusing to allow Black people to be involved in the study, to allow Black research to be involved in the study and all the rest. It wasn't unbiased. And they threw out 100 of 103 studies because they said they were low quality, even though medical treatment does not require, most medical treatment is not based on high quality research. And it's about it's a languaging thing that's in there. So there's a lot of pieces. I can go on and on about the CAS review. I would recommend, although likely if you're asking these questions, you may not go there, but you might look at Aaron in the morning or Aaron Reed's work and look at some of the data. Look at WPATH. The WPATH website put out a review of what the CAS review and the problems with it and how actually biased it is. I mean, she actually says that that gender diversity is caused by possibly social contagion and pornography. There's no data, absolutely zero on that. And there's a lot of data that says that gender affirming care actually works. So we have a lot of studies out there. They're not the large scale, there's not the longitudinal because of the time, and there's other issues that go on. But to throw out lots of data and then bring in something where there's none and say that this might be causing it is a little problematic. So make sure you get a very balanced look at any of the studies that you look at and make sure that you're getting that. So anyway, that like I said, I go on and I know we're at time. So
Might try, we're at time. Do you have a minute for one or two more questions?
sure, I'm fine.
So Norman Bell is wondering about recommendations regarding athletic participation for gender diverse youth.
Sorry. Well, as far as athletic participation, it's great. Athletics are awesome if kids are really interested in and involved in that. It's really good for bone density, especially. So if I have kids that are on blockers, I want them to be bouncing around and doing something that gets some of that exercise going. It also, team sports are really beautiful experience. It kind of depends on where people are and what the environment is around them. As in California, kids have equal access to athletics, even as trans kids, but also understanding what that means if they get on a national stage or international right now, that there's a lot of backlash around that. So I don't know what you mean by recommendations, but I highly recommend it. And it depends on the kid. You know, athletic participation depends on what their interests are, and whatever their interests are, if you can gear them towards it. It could be more solitary, hiking, you know, backpacking, doing stuff like that. Whatever it is great stuff. To get kids outside is awesome. Let's see, what resources are available for parents, particularly those who want to be supportive but have questions about how to best do that? Well, I would definitely recommend the Trans Family Alliance. We're actually not just a support group, but we're an educational resource center. We've got hundreds of hours of video out there. So that's one, it's Trans Family. You'll see it on, I think, on one of the slides. The other is,
I also put a link in the chat to the Trans Family Alliance Gender Journey.
yeah, and so the other is there's transfamilies.org. Gender Spectrum has a lot of information on their site. They no longer run support groups. PFLAG is another really great resource. So those are some of those that are out there for parents to help them get some information. There's also some great books. Actually, on the Trans Family Alliance website, we have a whole book list of things so parents can look through stuff like that.
There was a question about parents expressing concerns about chest binders, that they see that the recommendation is that they be used for 4 to 6 hours per day, but that teens tend to want to use them for more time than that. Any kind of recommendations for helping guide teens and families, and how do we decide if longer times are okay?
Yeah, it kind of depends on the kid and the size and all that kind of stuff. And, you know, most kids I know are not going to go with the 4 to 6 hours. They're at school longer than that. And it's again, a risk benefit analysis about, you know, the mental health of where somebody's at. Somebody's not really struggling around it. Having them really take breaks with the binder is great. Not likely to happen at school. So maybe when they come home from school, they take it off, but some kids can't even tolerate that. So you kind of got to weigh the mental health effects and the dysphoria that's related to that, as well as, you know, but when a kid is wearing it all the time, one parent was like, I have to practically rip it off the kid to wash it. So we have issues like that are going a little over the top, and just talking about them, about health and being able to breathe. I mean, a lot of kids do want to breathe, and sometimes those things are really tight and make it hard to breathe. And it also makes it hard to be involved in athletics. So It's one of the reasons why we start recommending, if they're on that journey and they've been on it for a while, that surgery, chest surgery might be a better option. If we're clear that that's the direction they're gonna go. And that's part of their embodiment goals. I don't know if that answered your question, but I basically talk about what the risks are of doing it, and weigh and look at options and opportunities and what you can do about it for health.
Well, thank you so much. I know we're a little bit over, and we just appreciate so much having you come and speak with us.
Sure.
And well, thank you.